Hi guys, welcome back. We shall now be talking about massive transfusion protocol. The definition for this has been replacement of the entire blood volume of the patient in a 24-hour period, which might be written as more than 10 units of whole blood that was administered to the patient. Though there can be complications also, but we'll definitely ensure that those complication rates are minimized. You will notice that in some multiple choice questions, instead of asking in units of whole blood, they have rather asked about volume of blood that has been replenished. So an alternative definition is at least 5 units, that is 2.5 liters of whole blood, which has been given to the patient over a 4-hour period. So there are multiple definitions going on for MTP. The most recent one that has been asked and should be remembered by you is with respect to blood components, where we shall be giving to the patient packed RBCs, fresh frozen plasma, and platelet-rich plasma. I want you to remember for MCQ sake that we will be giving 6 units of packed RBC, 6 units of fresh frozen plasma, and 6 units of platelet-rich plasma to the patient. These 6 units can be condensed into a single bag also. Like most of the time, we might be having availability of SDP, which is prepared via apheresis, that is a single donor platelet. The efficacy of a SDP will be equivalent to 6 units or 6 bags of platelet-rich plasma. They've also asked in the exam the ratio at which these products should be administered. Then the ratio would be 1:1:1, and the first thing to be administered is packed RBCs to treat the acidosis component in the patient. I would like to reiterate the statement once again. In a bleeding patient, he said what is the first thing to be administered, and lots of time on the internet the answer given by various websites is that it should be platelets in the patient. Please appreciate the fact that we will not give platelets first in a bleeding patient, because in a bleeding patient, due to exsanguination, because of loss of blood from the patient, there is hypoxia, there is acidosis, and therefore to neutralize that hypoxia and acidosis, we need to give packed RBCs which will carry oxygen and will neutralize the acidosis component. Why I'm worried about the acidosis component is because of the fact that acidosis will impair the ability of the blood to clot. That will worsen the coagulopathy of the patient. So in a bleeding patient, it does not mean that we are talking about a dengue hemorrhagic fever patient who's having a low platelet count. By bleeding patient, he means it could be obstetric trauma, it could be a surgical trauma, it could be hematemesis or vomiting of blood in a patient. So even if single IV line access is available, the first thing that we will give to the patient would be packed RBCs, then fresh frozen plasma and platelet-rich plasma. And as I will explain to you that there is a possibility that you may not use all of these components because person, even before you give them, might start recovering. So when will you initiate a massive transfusion protocol will be the objective of my discussion. Most of the time in the blood bank, they will be providing a red cooler bag. In this red cooler bag, inside this would be present 6 units of packed RBCs. Plasma may be initially stored inside, but then would be kept outside because you need to thaw the plasma. Please appreciate that plasma is stored at -30. So -30, it would be like frozen. It would be like ice. So you need to let it thaw and come to room temperature. So platelets are not kept in the cooler bag. You all know platelets are stored at room temperature between 20 to 24 degrees Celsius. So once the red cooler bag is obtained, you will keep the packed RBCs inside the cooler bag only. But when it comes to plasma, the plasma will be kept outside the cooler bag to let it thaw, and the platelets anyway can be kept outside at room temperature. And once you are done with packed RBCs, then you go in the sequence that I have tried to explain to you. Now, why the rush? I mean, why are we so paranoid about blood loss in a patient? So I would like to speak regarding the fact that if there is trauma in a patient, if there is a excessive blood loss in a patient, then coagulopathy can develop. You see, normally they teach you that massive blood transfusion can contribute to coagulopathy. But before that, I want to bring to your notice the fact that trauma or blood loss itself will result in development of coagulopathy. Why? Because when you lose blood from the body, the person will start developing cold clammy extremities. There will be hypothermia set up in the patient, loss of blood from the body, loss of heat from the body. So hypothermia would set in, and hypothermia itself will result in decreased ability of the clotting system to function. So therefore, you will read the term trauma-induced coagulopathy, where a person due to blood loss because of loss of clotting factors from the body will be having a development of increased bleeding tendency. Just to explain this better to you, I want to tell you that in human body, we just have only 10 grams of fibrinogen. Only 10 grams of fibrinogen, and in a massive blood transfusion, if that is lost, then obviously the person is in bad state. And then there is only 15 ml of platelets. I mean, if we consider all of the platelets, that is 15 ml of platelets. 15 ml of platelets would be like 2 teaspoons of platelet, 2 teaspoons of platelets in our whole body. So if I'm going to lose those platelets, I'm going to lose that fibrinogen, then well, God help me, because the blood of mine will not clot. So trauma-induced coagulopathy is definitely a reality, and to this, if you add now massive blood transfusion, because RBCs are stored at 4 degrees Celsius, when you will give that cold RBCs to the patient, the hypothermia component will worsen. The worsening of hypothermia component will further result in coagulopathy. So let us now understand the bloody vicious cycle that will set up in the patient. One, due to poor circulation, patient will be having metabolic acidosis because the cells will switch to anaerobic mode of respiration. Along with this, when you will be giving cold blood components to the patient, it will trigger development of hypothermia. Third, hypothermia will interfere with the clotting process, so it will result in coagulopathy. So this triad is a disaster situation in practice of any doctor, because one thing leads to another, and therefore it becomes very difficult for the patient to be managed. I'll just try to highlight what is given in the slide once again. I said the person is having, let me say, obstetric hemorrhage. So you are resuscitating the patient with massive transfusion protocol, but when you rush so much of crystalloids followed by blood transfusion into the patient, the hemodilution component will occur in the patient, hypothermia will be set up in the patient, and that will interfere with the clotting process, and that will worsen the coagulopathy in the patient. So one thing is leading to another. In fact, your resuscitation is contributing to trouble. So we need to ensure that we have an inline warmer in a rapid infuser pump that we have nowadays, so that the components are warmed to a sufficient temperature to minimize the chances of hypothermia in the patient, because that's one of the important triggers that results in impaired ability of the blood to clot. I'll highlight once again, human body has limited ability to achieve clotting, because all we have is 10 grams of fibrinogen and 15 ml of platelets. I mean, the platelet count is 1.5 to 4.5 lakhs per cubic millimeter. But if you add up the entire platelets, I said it is just 2 teaspoons. And if you drain that out of the body, then the chances of person dying is increased. In fact, they have documented this in clinical studies that if a person is having 150 ml of blood loss from the body per minute, that is pretty substantial. 150 ml of blood loss from the body per minute. It could be due to vomiting of blood, hematemesis, trauma, surgery, gunshot, whatever. Then most of the time, after 20 minutes, the amount of blood loss in the patient is so severe that he will go into decompensated shock. He will usually become pulseless, or they would be thready pulse with the unrecordable BP, and it will be a point of no return most of the time, because at this moment there is so much of depletion of the circulating fluid volume in the patient, that even if you try to aggressively resuscitate the patient, usually due to either complications of your resuscitation or due to the primary insult of blood loss in the patient, the chances of death in the patient will be increased. From Western perspective, I can give an example. Like this person, he went for swimming on the beach and he was bitten by a shark. The shark will, bite into the leg of the person. He is having his femoral artery lacerated. So on one hand, he's losing blood, and on the second hand, they're rushing in blood into the body of the patient. Then the input and the output should be equal, because if you lose that blood in that little a time span, the person would be gone forever. Or I can give an example of a soldier patrolling in, let me say, a terrorist-infested area, and he gets shot. He got shot in the leg where the bulletproof vest is in the upper part of the body. They shot him in the leg and he's bleeding from a popliteal artery. Then the input or the rush of blood into the body of this soldier has to be equal to the output before obviously surgical team takes over. Otherwise, you will lose the soldier for good. So the rush is mainly because you are having this triad coming up in the patient. The rush is because the decompensated shock in the patient will ensure a mortality. So therefore, from a doctor's perspective, you should be able to pick up, does a patient require a massive transfusion or not? Let us now take into consideration what are the triggers which will ensure that you will initiate massive transfusion protocol in the patient. The trigger will be most of the time a score that is called as ABC, that is assessment of blood component score. If the value of this assessment of blood component score is more than 2, then the person definitely requires a massive transfusion protocol. The components of this ABC score is: 1, presence of penetrating injury; The second component to be remembered is positive fast. You all know from surgery fast that would be focus assessment with sonography for trauma. Then would be a heart rate of a person more than 100 per minute, and systolic blood pressure of the patient to be less than 90 millimeters of mercury. Each of these parameters are given 1 point each. If a person is having a composite final score of 2 or more than 2, then it has been documented in clinical studies that there is 75% accuracy in the prediction for requirement of massive transfusion protocol. You see, most of us, because we see so much of blood loss for first time in our life, like a person came to my OPD, he had vomiting of blood that may be only 200-300 ml, but if a person will vomit 200-300 ml of blood in front of you, that blood on the floor might look like an extensive amount, and because I've seen it for first time in my life, I might be rather tempted to immediately initiate a MTP protocol. So they said that over usage of resources in the hospital might create a shortage, so they have said that we will not rely on the experience of the doctor, because for me, as a first case of my life, 200 ml of vomiting of blood might be very extensive. So he says that over usage of resources will occur, shortage can occur, so it is recommended that only few physicians are given the power to initiate massive transfusion protocol, and even those physicians are not going to initiate it on the basis of the clinical experience. Obviously that matters. They will initiate that on the basis of a software algorithm, which is a straightforward assessment of blood component score or ABC score, and the score is more than 2, then there is a high accuracy that the requirement for MTP was a valid scenario for the patient. So let us now study regarding the setup which is required for initiating a MTP in a patient. One, you need to have availability of a pressurized rapid transfuser. Why it is pressurized? Because you need to give the blood components fast to the patient to match with the output, like he's literally pouring buckets of blood. So pressurized rapid transfuser will ensure blood components reach into the body of the patient on time. Wide bore cannula access has already been obtained, but if you are using a PRT, then the infusion will match with the output and the chances of survival will definitely increase. And the second thing that you need to remember here is that this device will also be having an inline warmer. So the problem of hypothermia that I was talking about with blood components can also be negated. And once the hypothermia part is negated, then the coagulopathy part will also be taken care of. And that is what we want. The hemostasis should be achieved in the patient, the clot should get formed, and therefore to help in that clot formation, clinical studies have shown that we will also use a drug by the name of tranexamic acid. This is an antifibrinolytic agent. It will stabilize the clot, it will stabilize the hemostatic mechanisms of the patient, and again the chances of bleeding in the patient will be minimized. So once we have these things in our mind, we will now decide on how to initiate MTP in the patient. So let us now talk about adult MTP protocol, that is massive transfusion protocol. The first and the foremost thing that we need to identify is the trigger for it. I have explained to you the trigger that we will use will mostly be a ABC, that is absolute blood component score of value more than 2, which indicates that the MTP has to be initiated. Or for that matter of fact, let me say, if I'm not using the score, but my person is having, during surgery there was a trauma to a major blood vessel, is having severe bleeding, or person is having hematemesis due to peptic ulcer disease, or it could be a obstetric hemorrhage due to postpartum hemorrhage, atonic uterus in a patient, and the gynecologist or obstetrician has given a call to the blood bank, or it could be simply a penetrating trauma in the patient. So surgical bleeding, GI bleeding, obstetric and trauma bleeding with hemodynamic instability is obviously a valid reason for initiating a MTP. Now once I will initiate MTP in round 1, the steps that would be followed by me will be in the following fashion. I will call the blood bank and inform MTP protocol to be initiated, and then I will assign team members whose job would be to do specific tasks. Why that is important is because every person in your team should be knowing what is to be done. So we are going to divide our teams into team A, B and C. The person in team C will mainly be a runner. His job will be mainly to go to the blood bank, get the cooler pack, come back to the hospital. So it could be intern, it could be resident, it could be senior resident, whosoever is volunteering for the activity, he could be a runner to go and get the blood units for the patient. The person number A, or the person whom assigned as team member A, his job would be A, can be used to remember that his job would be to administer blood components to the patient. However, this person will not be responsible for drawing any blood sample for the patient. He will not be responsible for labeling of any blood samples. Neither will he be responsible to make entry in the file of the units of blood that may receive from the blood bank, because sometimes there could be multiple cases of trauma-induced massive bleeding brought to your hospital. So two different patients are being managed simultaneously, or maybe five patients are being managed simultaneously. So person number B, his job will be mainly record keeping. Apart from record keeping, he will also be doing sampling in the patient. He will be doing labeling of the samples, and he will also be making an entry in the file of the units of blood and the RFID code or whatever code is mentioned on the blood bag. So he will make an entry of that on the file so that proper documentation is maintained, because lots of time, because of the massive transfusion protocol itself, person can die. So we need to be very secure from the medical legal perspective. That is why I assigned the team members, and that is what he says. So even in the exam, if he says that what is the first step to be done after calling the blood bank, first is assign team members, so that you know that who's giving the massive transfusion, who's the one who's doing the sampling, and who's the one who's doing the running part. After that, I will be asking team member B, who is also responsible for sampling, to draw a blood sample of the patient for the following things: complete blood count, complete metabolic profile. Metabolic profile would mean LFT, KFT of the patient, coagulogram, that is PT and activated partial thromboplastin time, and a ABG of the patient from the radial artery, so that we can know regarding the metabolic acidosis component of the patient. Next, I will be asking team member number A. Remember, he is the one who is responsible for administering blood component or any other product to the patient. So to team member A, I will ask the person to give 1 gram of tranexamic acid to the patient. This is an antifibrinolytic agent which has been documented to be a great efficacy, especially in surgically induced bleeding. This 1 gram IV will be given start to the patient, and then we can give it 8 hourly to the patient, and it has documented excellent results. So IV tranexamic acid will be administered by team member number A. Now I will be asking team member number A to connect and prime up the system. That is, he will basically connect the pressurized rapid transfuser to the patient. He will prime the pressurized rapid transfuser with the units of blood which have now been obtained by team member number C, and he will connect the pressurized transfuser to the patient, and then we will give the patient 4 units of packed RBCs, and we will be giving to the patient 2 units of fresh frozen plasma. Remember, from the blood bank I obtained a bag containing 666, but in round 1 I will not give all 666. I will give 4 units of packed RBCs and 2 units of fresh frozen plasma to the patient. The packed RBCs will obviously be O negative, fresh frozen plasma would be AB positive, and once we give these to the patient, I will most of the time have a recovery, in a sense that the bleeding part might significantly reduce in the patient. I will reassess the patient at the end of round 1. On reassessing, if he improves, great. Otherwise, we go to round 2 in the patient. So, assuming the fact that there is no improvement in the patient, he is still pouring buckets of blood, is still bleeding. In those circumstances, I will next go to round 2 in the patient. So, we will now study what is going to be done in round 2 and how is it different from round number 1. In round number 2, I will now be once again infusing 4 units of packed RBCs, 4 units of fresh frozen plasma, and 1 unit of single donor platelet to the patient. Remember, initially I did not use the platelets in round 1, but now I have used platelets for my patient in round number 2. I will resend the labs of the patient. So team member number B will be responsible for resend the labs so that I can evaluate the improvement in the coagulopathy component and the metabolic acidosis component of the patient. I will now be giving calcium gluconate to the patient. Why calcium gluconate? Because there is citrate in the RBC pack, and that citrate binds with calcium and it can trigger tetany. So to prevent the development of tetany and a possible laryngospasm, remember tetany causes death due to laryngospasm. So to prevent the development of tetany, calcium gluconate will be given to the patient in round number 2, and he says that you may even use cryoprecipitate. Now, this is a new thing which I did not mention initially because most of the time we use only RBCs, fresh frozen plasma, and platelets. But cryoprecipitate may even be required if the fibrinogen values in the patient are turning out to be less than 100 milligram per liter. So do remember the fact that in round number 2, 3 extra things are being done. What are the extra things being done? You are giving platelets to the patient, you are giving calcium to the patient, C, and you are giving cryoprecipitate to the patient. This was not done in round number 1. Round number 1 is about tranexamic acid and obviously RBCs and plasma, but no platelets. In round number 2, it is platelets with calcium with cryoprecipitate. Most of the time your patient will improve. If your patient will not improve, one, I can say just God help this guy, but yeah, I'm not gonna give up and I'm gonna take another round. So like in boxing you have multiple rounds, you are going into round 3 for management of this person. Let us now see what will we do extra in round number 3 for management of this patient. He says first step in round 3 will be that you have to repeat round 2 aspects, which is that you are gonna once again give to this patient 4 units of packed RBC, 4 units of FFP, and 1 units of single donor platelet. This was round number 2 that I'm talking about. The steps of round number 2 have been repeated in the patient. And now the extra thing that I will do here will be to administer factor 7A. So let us look at indications for giving factor 7A in the patient. One of the indications would be the surgical hemostasis has been achieved. The body temperature of the patient has also stabilized. When he came, he was hypothermic. Now the body temperature is up to 37 degrees Celsius from 35. The pH of the patient has also stabilized. The initial pH of the patient was 7.2. Now it is stabilized to 7.35, 7.36. So you have taken care of the metabolic acidosis and the hypothermia component of the patient, but is still bleeding. That is when factor 7A would be given to the patient. So let's have a quick recap regarding the battle that we have fought for saving the life of this patient. This battle encompasses total of 3 rounds. In round 1 that I have discussed with you, let us revise the important components which are to be remembered. You will assign the team members for the respective jobs and there would be no overlapping, because otherwise if one person is doing all this, there can obviously be a wrong record entry and that can cause mayhem, because I'll discuss the complications also, and one of the biggest complications that can occur with components that we are giving is trolley. You see, trauma can induce coagulopathy. Blood transfusion can also contribute to coagulopathy. But when you give blood components, then they can trigger a transfusion-related acute lung injury also. Round 1, you have to assign team members to do their job. One person will be doing sampling of the patient and making a record entry. One person will be giving tranexamic acid to the patient, and then you give a pressurized transfuser based with the inline warmer, because the blood has to be warmed to a specific temperature and then given to the patient, and you will use only 4 units of packed RBC and 2 units of fresh frozen plasma with no platelets being used initially. Most of the time the bleeding will be controlled. If not, you go to next step where you will use platelets apart from obviously the fresh frozen plasma and RBC, give calcium to the patient and use cryoprecipitate. And if you still fail to secure the hemostasis in the patient, then you will again give RBCs and you will again be giving fresh frozen plasma to the patient along with platelets. But now you will be doing one thing extra, that is factor 7A to be given to the patient. This is the usual protocol which is recommended in most hospitals for management, and obviously there are local variations of the same also, but I would like you to remember at least this component so that when they ask you regarding the sequence, you should be able to answer it in the exam. So what are the challenges that we have fought during this massive transfusion protocol? One of the challenges we have fought is hypovolemia, because if we lose more than 40% of circulating fluid volume, person will go into decompensated shock, the BP will become unrecordable. So our objective is 2 things. One is obviously to stop the bleeding, whatever be the cause, and second is to replace the blood loss in the patient. And I've explained to you that if a person has lost more than 150 ml of blood per minute, then in those circumstances, the chances of death of the person is definitely increased. Another thing to be taken care is hypothermia in a component, because when you give blood components, like you are giving packed RBCs to the patient, because they are cold, so they will decrease the body temperature, and hypothermia contributes to coagulopathy in the patient. The hypocoagulability is the biggest challenge because trauma causes coagulopathy, blood components also cause coagulopathy. So most of the time, if you are able to handle this, then you will definitely be able to save the patient. And how do you handle this? I have spoken about usage of special products also, like tranexamic acid. I've spoken about factor 7A to be given to the patient, and also even apart from platelets, obviously, we have talked about tranexamic acid, we have talked about cryoprecipitate, and then also the use of recombinant factor 7A to be given to the patient. So we shall now discuss regarding complications of massive transfusion protocol or MTP. One of the important complications of massive transfusion protocol that is given in older books is coagulopathy. I have today tried to explain to you the fact that we are trying to minimize this coagulopathy because trauma also causes coagulopathy. We are trying to minimize this by using a pressurized rapid infuser with an inline warmer that will warm the blood component so that the hypothermia component can be minimized. We are giving packed RBCs to treat the acidosis component. So whatever derangements are contributing to bleeding, we are trying to address them. So in older books, you will notice that coagulopathy is one of the biggest complications of MTP, but now the concept is that coagulopathy is the trigger for MTP. Coagulopathy contributes to massive transfusion protocol being initiated. So our objective is now to basically control this coagulopathy. If you are able to control this, still person dies, then the cause of death is TRALI. Please appreciate the point. Coagulopathy was the trigger because of which he was bleeding. You have been successfully able to treat the coagulopathy patient, but still the person died. He did not die of bleeding, he died of non-cardiogenic pulmonary edema. Or another reason could be that you achieved a volume overload, like he was a heart disease patient and you did a volume overload, that is TACO. So if you read a question that says a person after massive transfusion protocol is having development of respiratory distress, then don't answer coagulopathy is the cause of death. Because coagulopathy will contribute to bleeding and shock. You have already addressed that, and the person is having respiratory distress, then the answer in the question is transfusion related acute lung injury. You see, questions nowadays are clinical oriented. So he said massive transfusion protocol was initiated in a patient of OBG by cause like a postpartum hemorrhage, and the person had developed respiratory distress. What could be the reason or etiology behind it? Then there are two etiologies. Either it is TRALI or it is transfusion associated circulatory overload. And how would you differentiate between them would be one, the value of blood pressure in the question, because blood pressure values will be increased in circulatory overload. In TRALI, the values of B-type natriuretic peptide will be normal, but BNP levels will always be increased in cardiogenic pulmonary edema, that is transfusion associated circulatory overload in the patient. So do remember the fact that TRALI and TACO are two reasons for respiratory distress after a massive transfusion protocol, and our objective is to clear the coagulopathy part component in the patient. So coagulopathy, I'm not saying that coagulopathy will not be seen. Yeah, it can be seen, but our objective is to clear that. So if he begins by saying that a transfusion protocol patient is having distress or is having increased blood pressure, cardiogenic pulmonary edema, crepitations in the chest, then these two possibilities have to be kept. And the two more causes to be remembered are development of electrolyte imbalance, hyperkalemia. Why that? Because packed RBCs were stored at lower temperature, they might be near their expiry date, so therefore their sodium potassium pumps have shut down due to depletion of glucose. So if the pumps will shut down, they will not be able to send potassium inside the RBCs, and therefore the blood potassium levels would be elevated. So hyperkalemia can contribute to diastolic arrest. So if he says after blood transfusion in a patient there is a bradycardia, then it is hyperkalemia that is occurring in a patient. On the other hand, if he says that a person after massive blood transfusion is having difficulty in breathing, there is a development of stridor in the patient, but the chest is clear, then it could be tetany occurring in a patient. So I'll just highlight the facts once again so that you can understand this. For respiratory distress, there can be three possibilities in a patient. The respiratory distress could be due to TRALI, it could be due to TRACO, or it could be due to laryngospasm that will trigger a difficulty in breathing in the patient. You will notice that pulmonary edema will be a feature of TRALI and TACO. TRALI would be non-cardiogenic, TACO would be cardiogenic pulmonary edema. And laryngospasm, the chest of the patient will be bilaterally clear, but you might be able to hear adventitious sounds. Those adventitious sounds are the sounds which are coming from the upper airway because there is a laryngospasm developing in a patient. But if he says there's a bradycardia occurring in a patient, then you have to think in terms of hyperkalemia in a patient. So complications of blood transfusion are obviously asked in the exam, and I've discussed them separately also with respect to transfusion biology. But here my main objective of discussing them and highlighting before you was just to sensitize you to the fact that in older questions they were not giving any clinical information. They were just saying massive transfusion protocol, person is still bleeding, what is the cause? Coagulopathy. But now they're saying he's having respiratory distress in the patient. Then answer is obviously not coagulopathy. It would be either 2 or 3 in a patient, or even 5 if the chest of the patient is clear. We have to keep our I would say senses open to the fact that these permutation combinations could be occurring in the patient. So these are details, guys, that I want you to remember for this topic. Thank you so much for listening, and we'll continue with another topic.